Our next presenter is Dr. Zhu Qin Yu, who is a cancer epidemiologist with the Cancer Council of New South Wales in Australia. He has extensive experience analysing cancer registry data and has a strong track record in peer-reviewed publications. He has his PhD degree from the University of Sydney. Put your hands together, please, for Dr. Zhu Qin Yu, please.
Hi, I'm from Sydney, Australia. Today I'm going to present you an Australian perspective for conditional survival of cancer patients. This is a map of Australia. And Sydney is the capital city of the state of New South Wales. This is the shaded area in this map. And New South Wales is the most populous state in Australia, with roughly about 1/3 of the national population. The data for this study were from the New South Wales Cancer Registry. New South Wales Cancer Registry is a population-based cancer registry, started operation since 1972. Traditional reporting of cancer survival is 5-year survival since diagnosis. However, this information is less informative if the patient has survived a period of time. They often ask this question: now I have survived for X years. What is the probability that I will survive another Y year? Conditional survival estimates address this question directly. For example, at the time of diagnosis, the 5-year survival could be 30%. But having survived that 5 years, the probability to survive another 5 years could be 70%. In this study, we estimated conditional survival for 11 major cancer types at different years since diagnosis, and also we stratified the conditional survival by age group, disease stage at diagnosis, the two important prognostic factors. As I said, we used the data from New South Wales Central Cancer Registry. The data include 11 major cancer types diagnosed in 1983 and 2006. The cancer registry also collects some information about spread of disease at diagnosis. It's similar like SEER summary stage, categorized as localized, regional, distant, and unknown. For survival follow-up, all cases were followed up to the end of 2006 through record linkage, linking the cancer registry record with those of state death register and national death index. Survival. We used relative survival for this study, and the data from a population-based cancer registry. Also, we used the period analysis method, and the period of interest is from 1998 to 2006. In period analysis, survival time was left truncated at the beginning of the period and right censored at its end. What is the conditional survival? Conditional survival was derived from the cumulative survival estimate. For example, 5-year survival conditional on having survived 1 year is calculated by 6-year cumulative survival divided by 1 year cumulative survival. Okay, let's move on to the result. This study includes over 190,000 cases. The 3 most common cancers are prostate, breast, and colon and rectum. The overall pattern is like this. 5-year relative survival tended to rise with increasing years survived. The greatest improvement was seen for cancers with poorer initial prognosis, including these aggressive cancers, those with advanced stage at diagnosis, and also for old patients. Because we include 11 major types, I will go through the patterns for site-specific. The first one is for prostate cancer. The y-axis is 5-year relative survival, and the x-axis is years since diagnosis. This is the age-specific conditional survival for prostate cancer. From this very simple graph, you can see all 3 lines are pretty flat. What that means? That means there was little change over time in conditional survival for prostate cancer. Probably because at the time of diagnosis, the 5-year relative survival is pretty high, so give you less room for improvement. The second pattern is conditional survival change. There are some change for these 2 types of cancer, but the change is very slow. And this one, there are some changes. I call that's a median change over time for these 5 cancers. Let's move on to the next. This one, that's for fatal cancers, for cancer of the stomach, pancreas, and the lung. From this graph, you can see at the time of diagnosis, 5-year relative survival were very low, but the conditional survival changed rapidly in first 3 years, and then it slowed down. Let's move on to the stage-specific conditional survival. These 2 for fatal cancer as well. So that's for cancer of the pancreas and the lung. So you can see survival at the time of diagnosis was very poor, no matter your localized stage or distant stage for these 2 types of cancer. And again, in the first 3 years, conditional survival changed dramatically. I group all these 9 types of cancer in one graph because the pattern are very similar. At the time of diagnosis, the difference in survival varied by stage at diagnosis. But over the time, all these 4 lines converged. At the time, at 10 years after diagnosis, you see the difference between conditional survival was very small. Okay, let's go to the discussion. This data provide important information, useful information for cancer patients to update their prognosis as they move along their cancer journey. Overall, the longer a patient survived, the longer he or she would expect to survive. For long-term survivors, their survival outlook would be much better for the next 5 years than they did at the diagnosis. This data indicate that hope is both real and realistic. Thank you for your attention.
Questions for Dr. Yu? Yes, we have a question here.
Thank you very much for this very interesting presentation. I wonder if you have an interpretation about stage, because you showed that conditional survival after several years of survival becomes better for advanced stage than for early stage. Can you interpret that?
Sorry, what's the question again? You know, for the advanced stage, the conditional survival
becomes higher than
higher.
For early stage.
Okay. Yeah.
Yeah, this is
Okay.
this is the big.
That's fine. Okay. And I think probably that's because one thing is, you know, because the cancer is very fatal, so most of them died in the first year or the second year. So at the time of 5 years, only a small number. So give you a lot of variation. That's one thing. Another possible reason is probably, you know, the states are misclassified. Another one probably also contribute to this is because we use the passive linkage with the cancer registry data with, you know, the death record. So some of them might be mismatched, cause, you know, immortal for some advanced stage patient.
So you think it is mostly for some kind of bias?
Yeah.
But I would like to suggest an alternative interpretation, that advanced stage are treated very aggressively at the beginning. Sometimes we kill the patient with the treatment. While early stage, perhaps, do not do adjuvant chemotherapy. So, after this very high risk for the advanced stages in the first years, at the end, those who survive are those who don't have silent, distant metastases that may occur in those who had earlier stage. But well, we can discuss later on this.
Yeah, it's conditional survival actually is natural selection. Usually this stronger, you know, survive. Stronger, of course, you know, have a higher probability of survival. That's a natural, you know, selection process.
Thank you so much, Dr. Yu. Our next presenter is Dr. Claudia Almani. She got her mathematics degree from the University of Turin in Italy. She completed a master's in statistical and information methods from the University of Milan, went on to get a PhD in medical statistics and public health in 2006. She recently joined the Cancer Research UK Surveillance Group in October of 2011 as a lecturer and epidemiologist. She's going to speak with us on colon cancer survival in the US and Europe, a Concord high-resolution study. Join me in welcoming Claudia Almani.
Thank you. First of all, I would like to thank all the contributors to this study that I couldn't include in the abstract, all the contributors from Cancer Registries, for the Centers for Disease Control in Atlanta, for the Istituto Nazionale dei Tumori e Istituto Superiore di Sanità in Italy, and of course the colleague from the London School of Hygiene and Tropical Medicine. Colorectal cancer survival is reportedly higher in the US than in Europe, and the first worldwide study, Concord, including 101 cancer registry from 31 countries, find wide differences in age-standardized survival. And during the early 90s, the survival differences in colorectal cancer survival were mainly attributed to stage diagnosis. The aim of this study is to compare the stage distribution in Europe and the US to determine whether these transatlantic differences still persist in 5-year survival, and to assess the extent to which these differences can be attributed to the stage distribution. In this study, we compared also the adherence to standard care for colorectal cancer in relation to stage and age, but I'm not going to show you these results due to limits of time. We included in the study about 13,000 patients with primary invasive colorectal cancer diagnosed in 1996 to 98, all adult patients from 21 cancer registries in 9 European countries and from 7 US states included in the National Program for Cancer Registries. For all these cases, information on stage, diagnostic procedure, and treatment were collected on a sample basis. We asked for about 500 cases for each cancer registries, and this information was collected going back to the clinical records. This is the reason why these studies are so-called high-resolution studies. In particular, we added in a second time the cancer registries of North Netherlands, because these registries collecting routinely for all cases this kind of information. And all patients were followed up for at least 5 years. The data quality was pretty high, and we could include 99% of the patients in the survival analysis. We estimated the net survival and the excess hazard of death. The net survival is the survival for cancer patient in the hypothetical situation in which cancer is the only possible cause of death. We estimated it can be also interpreted as the cancer survival for cancer patient after controlling for the competing risk of death. We estimated this using the flexible parametric models, where the total hazard is given by the sum of the hazard due to the cancer and the hazard due to other causes that can be estimated from all-cause mortality life tables. We used the life table produced by Paolo Bailey by sex, age, calendar period, and country in Europe or state in the US. We included age in all the models as a continuous variable and model it with restricted QB splines to avoid further potential bias due to the different frequency of the competing causes of death in the different age categories, more frequent in the elderly. And we included also stage and the number of lymph nodes examined as categorical variable in the model. All the models were tested and implementing using the tools developed by Paul Lambert, STPM2, and in which we included also the potential non-proportional effects of the covariables, and we assessed the goodness of fit using the Akaike information criterion. This table reports the stage of diagnosis in Europe and in the US. If you focus on stage A and B, you can see that the proportion was almost equal in the two areas, while we found a proportion that was double in the US regarding the Dukes C, and the reverse regarding the Dukes D, that were 22% in Europe and 10% in the US. Then we also found that the highest proportion of Dukes A was in Eastern Europe. If we look at the distribution by stage in the US states, we can say that it is rather similar, with the exception of the Louisiana state, in which the proportion of Dukes D was more similar to the European areas. Here, the Northern Europe is represented by Finland, the Western Europe is represented by North Netherlands and France, Southern Europe by Italy, Spain, and Slovenia, and Eastern Europe by Poland, Estonia, and Slovakia. If we look at the 5-year age standardized net survival, standardized using the Corazziari standard, we can see that the survival was higher in the US compared to Europe, 58% to 50%, and we can see a gradient from north to south in Europe, with the lowest survival in Eastern country. Going more deeply in the distribution by country and state, we can see a wide variability among the European countries, but also a rather wide variability among the US states, with the lowest survival in South Carolina, where we know that 30% of the population is represented by blacks. If we go more in deep at the 5-year survival by Duke stage, we can see that the survival was higher in the US for Dukes A and B, and higher in Northern Europe, here represented by Finland, for the cases staged as Duke C or D. We also looked at the mean excess hazard of death for 1,000 person years at 1 month, 6 months, and 1 year, 3 and 5 years. And from this, we can see that if we consider all ages together, the excess risk was always higher in Eastern Europe until the 3rd year. And this is mainly due to the elderly, but we found a similar pattern also for patient aged from 65 to 74. We produced the same analysis by stage, where we can see a rather similar pattern looking at the Dukes A, and quite a large variability in Dukes D. In conclusion, at the end of the 90s, the differences in survival were still persistent, and we found a higher proportion of a higher survival in the US for Dukes A and D, and also, as I mentioned, we found this surprising high proportion of Dukes A in Eastern Europe, where actually the survival for Dukes A tumors is the lowest compared to the other areas. And so we thought that probably this is due to the downstaging leading to not proper treatment. But I would like to address the discussion to a more general point, that is the importance of this kind of study, because all the clinicians and epidemiology used to say that data on population-based data on stage and treatment are very important. And we believe that with the high-resolution study, we can find a valid way to get good quality data. We know that the proportion of missing for stage is still around 10%, but I think that we can be happy if we compare the proportion of stage in the whole population-based data set in many studies, in which it is around 50%. So my point here is that we believe that more funding should be addressed to help cancer registry to collect this kind of information. To conclude, I would like to tell you that we look forward to seeing you at the Concord meeting on Thursday and Fridays in this hotel, and I will thank you for your attention.
Questions for Dr. Al-Amani? Where's our microphone person? There we go. It's coming.
I noticed a high proportion of unstaged cases in Northern Registry. That surprised me because we know
it is not very surprising, because apparently the reason is that in Finland they collected pre-operative stage, and this is the data they put in their data system, and then when they finalize the staging after surgery, this is not routinely inserted in the database. And this is the reason why we decided to include anyway Finland, also because it's the only country we had in Northern Europe. In this study, I mean.
Thank you, Dr. Al-Amani. It's my pleasure to introduce our last speaker, so it won't be too long, but probably our best. No, we saved the best till the last. Our next speaker, Mika Arts, is an epidemiologist at the Eindhoven Cancer Registry. Her topic is the impact of socioeconomic status on prostate cancer treatment survival in the southern Netherlands. But before we recognize her, there's a very special reason why we should. In June, she successfully defended her PhD thesis. So join me in welcoming the new Dr. Arts.
Thank you for the introduction. Indeed, my topic of the presentation will be on socioeconomic status and prostate cancer treatment and survival in the southern Netherlands. In contrast to many other cancers, prostate cancer incidence is highest among males with a high socioeconomic status. This is also found in many other countries, and presumably the high incidence rate is related to the PSA testing, which appears to be more common among males with a high socioeconomic status. CES has been related to cancer treatment disparities in other cancers and in other countries for prostate cancer as well, with higher surgery rates. In the Netherlands, treatment disparities according to socioeconomic status have also been found. For example, colon cancer stage 3, chemotherapy rates are higher among patients with a high socioeconomic position. And this is quite remarkable given the fact that all inhabitants have obligatory health insurance and are thereby supposed to have equal access to health care, including oncological health care. These treatment disparities might result from differences in comorbidities. We previously observed that the prevalence of comorbidities among cancer patients is higher among cancer patients with a low socioeconomic status. For example, diabetes, cardiovascular diseases, and chronic obstructive lung diseases are more common among patients with a low socioeconomic status. This presentation will be on the relation between socioeconomic status and prostate cancer treatment and survival in the Netherlands. Our study questions were: is CES related to prostate cancer treatment, and is there a role for comorbidities? Is CESS related to the introduction of brachytherapy, which is a form of internal radiotherapy? And is CESS related to survival in prostate cancer patients, and is there a role for comorbidities? Well, you've seen this picture quite a few times before today, so I won't bother you. The main point here is that we used assess CESS, the socioeconomic status of the patient, at postal code at the time of cancer diagnosis. And on average, each postal code in the Netherlands contains 17 households, so it's quite a small area. And we use data from Statistics Netherlands, which are used to assess the socioeconomic status, and these are based on household income and value of the housing. I will only present the results for localized stage because these were most interesting. And in this figure, the treatment options are presented. As you can see, rates of prostatectomy and brachytherapy are higher among patients with a high socioeconomic status, the dark blue bars. In contrast, external beam radiotherapy and hormonal therapy were less common among patients with a high socioeconomic status. And watchful waiting was not significantly different between the CESS groups. In logistic regression analysis, adjusting for year of diagnosis and age of diagnosis, we found that the odds ratio of receiving prostatectomy and brachytherapy, these two, were reduced in patients with a low socioeconomic status. In contrast, external beam radiotherapy and hormonal therapy rates were higher, as well as watchful waiting, but none of these were significantly different. By adding comorbidity to the model, the number of comorbid conditions, we aim to investigate the impact of comorbidity on treatment selection. And as you can see, only the odds ratios only slightly changed and remained significantly reduced for patients with a low socioeconomic status, with a lower chance of receiving prostatectomy and brachytherapy. And we think that this might be related to the patient preferences, with the patients of a high socioeconomic position preferring prostatectomy or receiving brachytherapy. And we also investigated the introduction of brachytherapy, which is, as I said, a form of internal radiotherapy in which radioactive iodine seeds are placed into the prostate. And this form of radiotherapy was introduced in the end of the 1990s in the southern Netherlands. And the introduction took first place in the patients with a high socioeconomic status, the dark blue line, and later on also in the patients with a low socioeconomic status, the pink line. Further analysis revealed that this was not related to the prevalence of comorbidities, suggesting that indeed patient preferences might have led to these associations. Looking into the results for overall survival shows that 10 years after prostate cancer diagnosis, approximately 75% of the patients with a high socioeconomic position are still alive, compared to 52% of the patients with a low socioeconomic position. In Cox regression analysis adjusted for year of diagnosis, the hazard of death, the hazard ratio for low compared to high socioeconomic status, is significantly increased with a hazard ratio of 1.7. Adding comorbidity to the model and therapy to the model slightly reduced the hazards of ratios, but still the hazard of death remains significantly increased in patients with a low socioeconomic position. However, it should be noted that we don't know the cause of death, and patients with localized prostate cancer have low lethality, so these differences might be related to other factors. To summarize our findings, we observed that patients with a high socioeconomic status more often receive prostatectomy and brachytherapy for their localized prostate cancer, and these differences are only partly explained by the higher prevalence of comorbidities among patients with a low socioeconomic status. Brachytherapy was first introduced in patients with a high socioeconomic position, and overall survival is best in patients with a high CESS, with a small role for comorbidities and treatment selection. This suggests that other factors could play a role in these socioeconomic inequalities. For example, patient preferences like we saw for brachytherapy, or health literacy, hospital variation, or personality, or perhaps other factors. Thank you for your attention.
Questions for Dr. Arts?
Thank you for your presentation. If I'm well informed, as many presentations of this area has been done today, there are only 2 radiotherapy centers in this area. Have you been looking at the distance between the place where the patient is located and the radiotherapy center? Because it might be some kind of preference of the urologist.
That's true.
Thinking about the fact that, well, radiotherapy department is too far away. So it has nothing to do with the social economical status, but with something else.
That could be, but I suppose the regions of the radiotherapy department not to differ socioeconomically. Around the radiotherapy departments, I expect the distribution of the size of the patients to be similar, so that wouldn't change.
Okay, but are you sure? Because where they are located...
I don't know.
Maybe you should...
It's a good point. I agree.
Maybe you can look at it, because if you have the data, you can look at the differences.
Okay. Thank you.
Okay, without any other questions, oh, we do have one more. Okay, one more. You get to be the last word.
Thank you very much.
No, actually, Harry gets to be the last word.
Oh, okay. If we assume differential uptake of PSA testing by socioeconomic status, do you have any evidence or a feel for if there's a different stage at presentation which would necessarily affect treatment options and outcome?
Mm-hmm. Well, I also looked into the data for the CT1C stage, which is the PSA detected stage, and this stage was more common among patients with a high socioeconomic position, not surprisingly. And similar patterns were observed for the patients selected on CT1C stage.
Thank you so very much, Dr. Arts. Before Harry gives us our marching orders, we have Tony Moran's ticket for dinner tonight. If you want it, we're going to leave it right here. So, and I believe, Harry, do you have last words for us?
Yeah, that's if Tony Moran wants it now.
Yeah. Otherwise, we're going to take it. No.
2 very quick announcements. The buses for the city centre will leave as soon as you get downstairs, essentially, and they'll leave from the back of the hotel, which is just down at the bottom of the stairs and out through the doors. Buses from the city centre back here will leave the hotels at 20 minutes to 8. There will be a reception in the atrium of the hotel where the original welcome reception was at 8 o'clock, and the dinner will be in this room at 8:30.
Enjoyed that, Tom. Thanks. I enjoyed working with you.
It's great to meet you.
Yeah.
Are you going to join us?
I'll be here later on, yeah.
Excellent. It's always a lovely party.
Yes. Yeah, sure. I'm sure. Have you all your belongings? Here's your lovely pen.
I have my important,